Syringe infusion pumps are an important part of our clinical practice, but as with any sophisticated device, there are some important considerations to keep in mind as you use them to continue to provide excellent care. These considerations when using syringe pumps may not always be clearly evident, and without understanding the mechanisms and physics of how these pumps function, unintentional complications may arise. Consider the following 3 scenarios where unintentional complications arose while using syringe pumps. If you are unable to decipher what caused these events to occur, you will be able to by the end of the first 2 modules in this series. In Scenario 1, a premature neonate delivered at an outlying hospital arrives at the NICU receiving a number of infusions for blood pressure support. In order to accommodate and organize all the pumps, the nurse moves a syringe pump infusing dopamine from a position level with the neonate to the top of an IV pole. Less than a minute later, the baby's heart rate has increased from 120 to over 200 beats per minute. In Scenario 2, an ICU patient in septic shock has just been started on a norepinephrine infusion. The rate is set correctly, and the line is not kinked or clamped. Yet 15 minutes after starting the infusion, the patient's vitals still show no evidence of medication effect. And in Scenario 3, within the PICU, an occlusion alarm sounds on a congenital heart disease patient's syringe pump, delivering a continuous infusion of nitroprusside for hemodynamic support. The patient's blood pressure is higher than expected, having not been receiving their medication. The caregiver notices a stopcock was inadvertently left in the wrong position, creating a heart occlusion. The caregiver turns the stopcock to permit the flow to the patient and runs the infusion. 2 minutes later, the patient is suddenly hypotensive. If you would like to re-examine the scenarios, you can use the buttons at the top of the screen. Situations like these are concerning, but they can be avoided. This module series isn't intended to highlight anything currently being done incorrectly or practices needing to be changed. Rather, these modules are intended to bring knowledge and awareness of some topics we need to remain mindful of, so we know what to expect and how best to respond in certain situations. These modules also provide some guidance and recommendations to consider for helping prevent or mitigate certain elements of syringe pump operation that can result in undesirable clinical responses. Within this module, we will be discussing the following topics. Part 2, which is a separate module, will build on these topics and introduce a couple other syringe pump considerations. Syringe infusion pumps have the benefit of allowing us to precisely deliver concentrated IV medications at slower infusion rates than available to us with most large volume infusion devices, typically with excellent flow continuity. Moreover, when multiple concurrent medications are required, syringe pumps provide a particularly good mechanism for delivery when conservative fluid management is essential to our patients' well-being. While syringe pumps have historically been used for delivery of short half-life, continuous medications, their limited volume capacity requires daily or more frequent changes of the syringe. This repeated action poses several significant unwanted effects, including exposure of the fluid path to airborne pathogens and delayed commencement of flow. The design of some modern large-volume pumps provide accuracy and stability found sufficient for continuous long-term infusions without periodic interruptions in exposure. While large-volume pumps are not without their own liabilities, the trade-offs between the use of large-volume and syringe pumps should be carefully weighed in view of the flow rates and pharmacokinetic characteristics of the continuous medications being delivered. Within the United States, 3 specific patient groups where the benefits of syringe pumps are commonly put to use are neonate and pediatric patients and fluid-intolerant patients, such as those with impaired kidney function. With neonate patients, you are dealing with some of the most vulnerable patients. These tiny patients are often in a critical state where they are receiving multiple life-supporting drugs being delivered at extremely low flow rates. Pediatric patients carry similar concerns, but flow rates are often not quite as low. For adults with organ system failure requiring fluid restriction, syringe pumps allow the administration of highly concentrated medications with relatively limited fluid intake. For each of these patient groups, the accurate, dependable, and continuous delivery of IV medication while avoiding fluid overload is a critical concern. Syringe pumps have clear benefits for these very vulnerable patients. However, syringe pumps require nuanced clinical practices, without which the risks of the following undesirable circumstances may be present. These circumstances, in turn, can lead to hemodynamic instability, loss of sedation, and increased pain, amongst other clinical concerns, some of which can be very serious. To preserve the benefits syringe pumps have to offer us, there are some important elements about the mechanisms and physics of how they work that you should understand. You may not be fully aware of these elements of operation, and they will be the focus of these modules. Please note that for high flow rates or drugs with long half-lives, such as antibiotics, many of the topics discussed in these modules may be minimal in their impact. However, when syringe pumps are used at slow flow rates, such as rates less than 3 milliliters per hour, or to deliver continuous drugs with short half-lives, such as cardiovascular drugs, these topics are essential to be aware of and have practices in place to minimize their impact in certain clinical situations. Syringe pumps have changed a lot over the years, and currently there are many makes and models in use. Yet, despite differences in appearance and features, most syringe pumps operate by the same general mechanism. It is important to first briefly discuss this mechanism, as it will be important to understanding some of the topics in these modules. Here is one mechanism of syringe pump operation. Within the device is a long drive shaft with threads. Clamped onto this is a split nut, shown here in red. The nut is attached to the part of the pump that pushes down on the syringe plunger. There is often a lever or tab that opens the capture arms which hold the syringe plunger button in place. This same lever also opens the split nut and allows the pushing mechanism to move freely up and down along the drive shaft. With the syringe in place, we can release the lever to secure the syringe plunger button within the capture arms. This also allows the red nut to once again lock onto the threaded drive shaft, preventing further movement of the pushing drive by any means except the motor. When the pump is started, the motor rotates the drive shaft and the nut moves downwards along the spinning threads. This in turn moves the pushing drive, which depresses the syringe plunger and forces fluid out of the syringe. The flow rate is controlled by how fast the motor turns the drive shaft. The nature of this mechanism means that there are some implications as to the reality of how medication is delivered by syringe pumps at slow flow rates that you may not have realized. When you program a flow rate, you may expect the pump to instantly and continuously deliver at this flow rate for the duration of the infusion. In turn, you may expect the volume infused to the patient to steadily increase at a consistent rate. However, this is not the reality of the situation, and the flow rate and volume infused may look a bit more like the images now shown. We will discuss why this is in the sections ahead. Pressing start on the pump does not necessarily mean that the patient instantly starts to receive the medication. The mechanical design of the pump and the properties of the syringe and tubing can combine to introduce an inherent delay in delivery. This delay can be on the order of tens of minutes, or potentially an hour under certain conditions. But there are steps you can take to mitigate this delay. The delay is a result of slack due to the mechanisms of the pump and the elastic properties of the syringe and tubing. After priming your IV tubing and inserting the syringe into the pump, a series of key events have to occur within the pump after you press run. These events must occur before fluid will flow through the tubing and into the patient at the set rate. These events start with the motor mechanically engaging with the pushing drive, essentially the nut latching onto the threads of the rotating drive shaft. This is followed by the pushing drive moving to make contact with the syringe plunger button. This includes the compression of any mechanisms over the plunger button, such as a pressure sensor. If there is a gap between the plunger button and the pushing drive, there will be a delay as the pump moves to close this gap. Next, before the syringe plunger actually starts to move, the rubber head of the plunger must overcome the friction of the syringe barrel that is opposing its movement. The force required to do this is called the breakout force, and it takes time for the moving pushing drive to build to this force before the plunger actually starts to move. Typically, the breakout force is less in smaller syringes, so the delay is smaller. Furthermore, if there is back pressure within the IV setup, it serves to actually oppose the flow of fluid to the patient. As a result, a few other events occur in response to back pressure before the fluid flows from the syringe. The plunger head is often soft rubber, and when it encounters back pressure, it will compress as the plunger starts to press on the fluid. In addition, as the syringe builds force to overcome this back pressure, the walls of the syringe barrel may expand. The degree of this compression of the plunger head and expansion of the syringe barrel will vary depending on the back pressure and elasticity or compliance of the syringe components. The more elastic the components and the higher the back pressure, the greater the delay. Only once all these events occur will fluid start to flow through the IV tubing to the patient. While each of these events alone may seem minimal, they can add up to a significant delay before the patient starts to actually receive their medication at the intended rate. For example, when infusing at 1 milliliter per hour, a 5 milliliter syringe may take up to 15 minutes before the patient starts to receive their medication. This delay gets longer with increasing syringe sizes, and 60 milliliter syringes infusing at 1 milliliter per hour may take up to half an hour. In addition, the slower the flow rate, the longer the delay will be, because the pump is moving more slowly, meaning each of these key events will take a much longer time to finish. In certain situations where larger syringes are infusing at slow flow rates, the startup delay may even be over an hour. To mitigate the duration of the delay, you must be sure to run the pump prior to starting the infusion to remove slack from the setup. This process of removing slack prior to the start of medication administration is primarily called priming on the pump, and sometimes purging the setup. Please note that this should be considered a distinct process from typical hand priming. Hand priming is done for the purpose of removing air from the IV tubing and is often accomplished without running the pump and will therefore not remove slack. Performing the process of removing slack will be different depending on the model of pump you are using, but the essential process is to allow the pump to run with the syringe and IV tubing inserted while preventing the patient from receiving any fluid. Some syringe pumps have a manual priming, bolus or purging button, or menu option that can assist with this process. However, you should never prime on the pump if fluid can flow to the patient. Typically, this means removing slack prior to connecting to the patient. If fluid flow were permitted to the patient, this process of priming on the pump would deliver an inadvertently large bolus. In order to assist with removing slack, one institution designed and implemented IV tubing sets incorporating an inline stopcock near to where the tubing attaches to the syringe. When priming on the pump, this design allows for the redirection and venting of flow to the external environment while preventing flow to the patient. The benefit is that the pump can now be run to remove slack, and you have easy, safe flow visualization without needing to disconnect the patient's IV tubing. During the few seconds in which the inline stopcock is open to the air for flow visualization, it is essential to maintain aseptic technique. Another way to help minimize slack is to be mindful for the presence of a gap between the syringe plunger button and the pushing drive. Historically, some older models of syringe pumps had capture arms that only loosely restrain the plunger button, allowing for a significant sized gap. However, Most modern models of syringe pumps have better fitting capture arms that grasp the syringe more securely, minimizing this gap. It is important to recognize, though, that disposable syringes can vary significantly in their dimensions based on the manufacturer, including the size of the plunger button, specifically its thickness and diameter. Furthermore, different models of pumps have different types of capture arms for holding the syringe plunger button in place. These capture arms may not be designed to tightly hold all the different makes and sizes of syringes perfectly in place. Your institution should select syringes with a plunger button that fits best within the capture arms of your model of syringe pump to help minimize the gap and the resultant delays. While removing slack may not mean there won't be any delay, it will go a long way to minimizing the delay. For example, priming on the pump may reduce the delay to a matter of a couple of minutes rather than upwards of 10 minutes. Therefore, it is good to prime on the pump before starting your infusion. It is also important to just be aware that even after removing slack, there may still be a bit of a delay before you can expect your patient to be receiving the medication. In summary, with regards to starting the syringe pump, here are some guidelines and recommendations to consider for helping mitigate the topics we just discussed. Despite setting a flow rate on the pump itself does not actually measure the flow rate. Over the course of the infusion, there can be irregularities in the flow pattern, meaning we don't maintain a continuous smooth flow rate at the programmed rate. The largest influencer of these irregularities in flow is the syringe. These irregularities can often be minimized by being mindful of the size of syringe you use, as we will discuss in the section ahead. Syringes come in different volumes, and in general, the larger the volume, the greater the syringe's diameter. If we take a cross-section of several different sizes of syringes, we illustrate that the larger the diameter, the more fluid that is displaced with each movement of the syringe plunger. The same small movement of the plunger results in different volumes being forced from the syringe. This implication of syringe diameter is important to keep in mind going forward in the module. We will first talk about the syringe pump's impact on flow stability. Each time the motor moves in a syringe pump, it serves to push the syringe plunger a tiny bit. We will call this movement a step. The size of this step is less than a micrometer, and it is the smallest movement achievable by the pump. The amount of fluid accompanying this step varies with syringe diameter. The frequency that these steps occur is how different flow rates are achieved. Conceptually, we can think of medication being delivered in a series of tiny shots of fluid and short periods of no delivery. However, these shots of fluid and periods of no delivery are minuscule for the most part. In general, only when large syringes are used at slow flow rates will there be implications to the precise and continuous delivery of medication. For large syringes with a bigger diameter, each step forces a greater amount of fluid out of the syringe. This means, when compared to syringes with a smaller diameter, larger syringes require fewer steps to administer the same volume of fluid. Furthermore, in order to deliver this volume over the same duration, the steps for larger syringes are more spaced apart. Therefore, for large syringes, this means there are bigger time gaps where no fluid is flowing, resulting in reduced flow continuity. The larger the syringe, the more continuity is impacted. For most sizes of syringes and faster flow rates, this stepwise nature of delivery is negligible and could essentially be considered continuous. That said, flow stability might be affected at slow flow rates, such as those under 0.3 milliliters per hour, where steps may be infrequent when larger syringes are used. For example, having a 60 milliliter syringe running at 0.1 milliliter per hour means that a step may only be occurring every 20 seconds. For fast-acting, short half-life medications, gaps between steps on the order of tens of seconds can lead to cycles of fluctuations in patient vitals. You can view this concept of flow stability and continuity yourself by watching the drops when a patient is not connected to the IV. You will notice how small syringes have drops consistently spaced apart, while larger syringes will have a few drops, followed by a gap of no fluid. For the best flow stability, consider using the smallest syringe that is practical for your clinical purpose. Certain models of syringe pumps may even constrain you from using certain larger syringe sizes when programming slow flow rates in order to minimize issues of flow stability. Since slow flow rates are the most susceptible when infusing fluids at rates below 0.1 milliliter per hour, it is recommended that you try to use a 3 milliliter or 1 milliliter syringe for the best flow stability. However, 1 milliliter syringes do have a limitation when used with some syringe pumps with regards to occlusion detection. We will discuss this limitation in the next module. We have just discussed how the pump influences the flow stability, but in general, its influence is small when compared to the level of influence that the syringe has. The biggest factor that will impact the flow stability is stiction. Stiction is the result of varying friction between the plunger stopper and the internal wall of the syringe. The interior of the syringe barrel is lubricated to reduce friction, but there can still be areas with varying levels of friction. Some areas may impede the motion of the plunger more than others. These areas of varying friction can be the result of inadequate or irregular syringe lubrication, varying syringe barrel internal diameter, or imperfections with the plunger stopper material. The varying friction as the plunger moves through the syringe barrel results in small irregularities in movement that create short-term cyclical variations in the flow that may have clinical implications. Stiction and these variations in the flow are most prominent when infusing at very slow flow rates. Syringe diameter has a role to play here as well with regards to stiction. The larger the syringe diameter, the greater the amount of fluid that can be inadvertently administered with each sudden irregular movement of the plunger. This can mean the size of the flow rate variations due to stiction may be greater with large syringes. Mechanical flexure is something else that can contribute to stiction. Mechanical flexure occurs when the syringe plunger is not aligned with the syringe barrel. If the pump's capture arms hold the plunger at a slight angle, such that when the pump pushes on the plunger, it pushes the rubber stopper into the syringe wall, this creates increased friction. This in turn will cause increased flow irregularities. Small syringes are particularly susceptible to this problem because of the way in which they may be grasped by the syringe capture arms. You should inspect if the syringes you use within your pumps are subject to this issue, and be observant when loading syringes to ensure you have proper alignment. In summary, while you cannot completely remove variances in the flow rate, you can take steps to minimize it. When using a syringe pump, here are some guidelines and recommendations to consider. That concludes part 1 of this 2-part series on syringe infusion pumps, how they operate, and the clinical implications. We hope it has been informative. The key things covered in this module to keep in mind as you continue to provide excellent care are: 1. Syringe infusion pumps are an important part of our clinical practice, particularly for neonate, pediatric, and fluid-intolerant patients. 2. Removing slack prior to administration will help minimize startup delays in delivery. And 3. Pump mechanics, stiction, and mechanical flexure will result in flow rate irregularities, which can be minimized by being mindful of the size of the syringe you use and ensuring proper alignment of the syringe within the pump. Delays and irregularities in flow may not be concerns in some situations, but they can be in others. So it is important to be aware of these topics so we know what to expect and how best to respond when we face particular clinical situations. Part 2 will build on the material presented in this module and discuss a few other topics to be aware of while using syringe infusion pumps. Upcoming topics include occlusions, height changes, and the selection of disposables. Part 2 will also revisit the clinical scenarios introduced at the start of this module.